The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Hi, welcome to the latest episode of Mental Health Now. I'm your host, Matthew Shapiro from NAMI-New York State, the National Alliance on Mental Illness. Today we're going to be discussing one of the most difficult yet important conversations we can have in the mental health field, and that's about suicide and suicide prevention. I'm very pleased to be joined by Dr. Perry Hoffman, who is the president and co-founder of the National Education Alliance on Borderline Personality Disorder. Perry, welcome. Thank you for joining us today.
Thank you, and thank you, Matthew, for having me and highlighting this subject. I so appreciate it.
Well, of course, and it's a conversation we need to have, and I think one of the biggest challenges we have in the mental health field, I sometimes say this is like a third rail topic. I think we're reluctant to talk about it. I think people are afraid if they talk about it and do something wrong, they get blamed for it. But I think the more education we have about suicide and preventing suicide, the better we can do. So before we get into suicide, I mentioned you are the president and the co-founder of the National Education Alliance on Borderline Personality Disorder. I think borderline personality is one of the most misunderstood and serious forms of mental illness. Can you just detail and describe it a little bit?
Sure. So this is a disorder that if we were to change the name, we'd call it emotion dysregulation disorder. It's about managing one's emotions and having problems doing so. It was given the name first mentioned in 1938 because it was thought to be on the borderline of neurosis and psychosis. We know now that it's not that. There have been pushes to change the name, but people say it's what it's known by. It would take a lot of effort, and we're working in other areas. But I do think that to identify that it's emotion dysregulation makes more sense to people because of what they are dealing with their loved ones or perhaps themselves.
Right. And when we say emotional deregulation, you're talking about people who can't manage their emotions properly and
right, who have difficulty staying within a range. So things are very intense, or some people will say, well, I never get angry. But in reality, they keep their anger so suppressed that it gets caught up, it gets played out in other areas that are not healthy.
Right. So actually, I'm all too familiar, unfortunately, with borderline personality disorder. I think you know my story. My mom was diagnosed after several different diagnoses over the years of manic depression, bipolar 1, bipolar 2, and then finally borderline personality. So I know one of the biggest conflicts with families with a loved one with borderline personality is communication strategies, and that can be a real challenge. Can you talk about that a little bit?
Well, when somebody has intense emotions, it's difficult to be able to stay the course of a conversation if they're very reactive. So with borderline personality disorder, we recognize that the person was born with certain emotional vulnerabilities. And those vulnerabilities, when they interact in the environment, whether it be with family members, with peers, with school personnel, that they react in intense emotions, it then gets a more intense reaction from the person they're communicating with. So just the way DBT teaches people to communicate more effectively, we know we also need to teach family members to communicate effectively.
Right. So we're going to talk about DBT, Dialectical Behavioral Therapy, in a second, but I want to talk a little bit about the work of the National Education Alliance on Borderline Personality Disorder and what you do. And you kind of mentioned it, that families do need a lot of education when working with a loved one or communicating with a loved one. So can you talk a little bit about the work that your organization does and the trainings that you offer?
Yes. So we got started in 2001, actually, 3 weeks before 9/11. And what spurred us to do this is there was a major conference at Rockefeller University with many of the key researchers there. And one psychiatrist, Dr. Alan Francis, who's well known in the field, said something about NAMI not taking BPD under its mission umbrella. Now, I used to work in the field of schizophrenia, so I know NAMI from many years back, from the original starters of NAMI, and I was just surprised. I assumed NAMI took it on. So several of us I was the professional, and family members and consumers decided to meet. And we met in August of 2001, and we decided, let's start this organization, and let's model what NAMI's doing for other organizations, and we'll do that. So we decided to first do a conference. We hosted a conference a year later at Columbia University. There were over 450 people there, and we were fortunate enough to get many of the key players, John Gunderson, Marsha Linehan, and then people known to NAMI like Lisa Dixon, Harriet, and I'm just blanking a name, and I love her.
Harriet Comfort?
No. Oh, it'll come back to me because she's written. She's just an amazing woman. Kristen Beals. I mean, there were a lot of well-known people from NAMI who came to support this effort. And then from there on, we got some grants from the National Institute of Mental Health. They gave us money to do 5 conferences. Because we're an all-volunteer organization, we parlayed that into 30 conferences.
Wow.
And then our next grant from NIMH was for 3 more conferences, and we parlayed that into another 15. So we've done, as you said, we've done about 70 conferences, and what we're very fortunate enough now that we really are a catalyst. And so what happens is that people turn to us to help them get things going. So we're doing conferences all over. We're not the ones starting the conferences, but we help co-sponsor it, and then we also participate in it. So that's one thing that we do. And then very nicely in 2006, NAMI National hosted a BPD experts group for 2 days in Arlington, and from then NAMI took BPD under its mission umbrella. So we work very closely with NAMI. We're so appreciative, NAMI New York State, because they really have set a mark that we're encouraging other affiliates to do. We appreciate you give us a table at your annual conference, and we tell every NAMI now that we'll come, but you have to give us a free table. We are not looking for services to be given to us. We're looking to service people. So that's who we are, and we also do a weekly call-in series. We'll be starting, I think, October 29th, and the focus will be on youth suicide and self-injury. It'll be a special series on Sunday nights for 12 weeks. Then we also have Dr. Charlie Swenson, who's going to be doing a call-in Wednesdays, I think at 4 o'clock, which will be just on talking. It'll be, we haven't come up with a name yet, but it'll be probably Talking with Charlie, where he'll do a lecture and then people can ask questions.
Fantastic. And one of the great things that you do too, which we haven't touched on, is the Family Connections group, which is kind of very similar to the NAMI Family program, which is discussed a lot on the show. And it says here, this is a skills-based program that offers a lifeline to families facing the challenges of borderline personality disorder. And I think that's so important, the lifeline, because I think a lot of times we say borderline personality is kind of like a perfect storm of mental illnesses, and families are often at a loss of it. So can you talk a little bit about the Family Connection? And I know we have a training coming up here in Albany, December 8th through 10th, which will train new Family Connection leaders, correct?
Exactly, yes. So our Family Connections program is modeled after NAMI's 12-week family-to-family program. And the impetus was because, as you well know, NAMI's family-to-family is wonderful. It's not disorder-specific. And there was not a lot, as there are not with other diagnoses, there was not a lot on borderline personality disorder. So I went and actually met with Joyce Berland, who is one of the most gracious people you could ever meet.
And Joyce Berland is the woman who created the family-to-family program.
Exactly. And she very nicely said, we just don't have room in the curriculum to do it. So I went back to New York and I met with my colleague, Dr. Alan Frazzetti, and I said, we've got to do something because NAMI's family-to-family is wonderful, but it's not giving skills to our families. So Alan and I designed the Family Connections program. We had the first group in 2002, and I was fortunate enough to have a KO8 award from the National NIMH, and that gave me 5 years to become a researcher and also to be able to design a research program. So what Alan and I did was we designed Family Connections, and we used the money from NIMH to do research on this Family Connections program. And what we found in our pilot, so these were brand new leaders, had never taught the course before, but we found that in spite of their relative inexperience in being leaders, that the group members that participated had lower grief, lower burden, lower depression, and higher sense of mastery. And all of those gains were maintained post 3 months after intervention, which means that families were using the skills. So that course now is in 19 countries, and it's we also do it by phone because we don't have leaders all over. We hope to put it as an online course, but right now the focus is online and in person. And unfortunately, my colleague Lynn Curry could not be with me today. Her plane from Montreal didn't make it to New York on time. But Lynn Curry is a mom who lost her daughter to suicide 5 years ago, and Lynn decided that she needed to do something from her experience. She never wanted a family member to go through that. She got trained in family connections along with her husband, and then she got a whole group of new leaders trained. And just for example, I called her about 2 weeks ago to set up a time to talk, and she said, Perry, this just isn't a good week this week. We have 30 new groups starting. This is one woman and her husband who did this. I went to, every year they have a suicide walk. I went to it in Toronto. There were over 700 people there. It looked like a conference that IBM had started.
That's fantastic. And before we pivot to discussing suicide specifically, one thing that you brought up that I do want to discuss, because it's such a game changer in borderline personality. I know one of the biggest challenges for providers, families, and people suffering from borderline is there's not a medication that you can take to treat it. The most successful treatments have been something that you already touched upon, dialectical behavioral therapy, which is an amazing thing. It's really, to me, learning about it's been life-changing. I've been lucky. I've seen Marsha Linehan, who designed it, speak a few times, and you've led workshops at the NAMI conference about well, I'll let you explain what DBT is and the benefits of using it with someone with borderline.
So dialectical behavior therapy, well, the first landmark article on it was in 1993. It was designed by a woman, as you said, Matthew, named Dr. Marsha Linehan. She herself was in the hospital for actually a year and a half when she was in high school, and she vowed that she was going to get herself out and she was going to get others out of hell as well. And she's a brilliant woman who put together this cognitive behavioral approach called dialectical behavior therapy, and it's very much about building skills. Borderline personality disorder used to be seen as a conflict disorder. It's now known as a deficit disorder. So when there are deficits, what do? You help people compensate and you teach them skills. So that's what DBT is about. It's about acquiring skills and building a life worth living.
And I think the skills that you learn in DBT, they're so beneficial. I think anyone should learn them. I think one of the most important things that we talk about, I think this is as we pivot towards suicide and understanding, is the skills of acceptance, which sounds so simple, but in some ways it's the most difficult thing to learn. Accepting that somebody is at point A now, you want them to get to point B, but maybe they're not ready for point B. So you accept where they are now and try to help them get them to where they want to be, correct?
Right. So the word dialectic means to find a balance between two things that seem opposing.
Right.
So the basic dialectic in DBT is radical acceptance and change. So it's acceptance and change, and that's what you always are juggling as a therapist working with someone with DBT. What do we need to accept, and then what can we change? And you keep going back and forth on that paradigm of acceptance and change.
Right. And I know, and it can be used, I mean, people can get diagnosed with borderline personality at a very young age, and that's why a lot of times when you hear about suicidal children, I mean, we're talking 6 to, it's usually they do have borderline personality, correct?
Well, let me say about borderline personality disorder, there are a lot of controversies around it. The name is one controversy. The even existence of the disorder was a controversy. It was thought to be a wastebasket diagnosis. The age of onset is a big one. The role of family members, and having worked in the area of schizophrenia and the schizophrenogenic mother, there was that same idea that mothers caused borderline. They don't.
Right.
We do know things happen in the environment. Some of them are severe. It doesn't mean the family is the one as the perpetrator of this. So we know there's a biosocial theory, and that's basically what's the fertile ground to develop the disorder. In terms of DBT, when I first started, I was part of the first training group. It was used for borderline borderline personality disorder, it's now a much wider umbrella. And just the way we're making a wider umbrella with borderline, with emotion dysregulation, DBT is being used for a lot of psychiatric diagnoses, and it's used as a preventative measure.
Right.
It's being used in schools where they're actually teaching it as part of a curriculum. It's being used with 5-year-olds to help them manage their anger better. So I think we have to not think of DBT as a borderline personality disorder specific. I do want to also make and you brought this up about your mother, Matthew, is that there's a lot of misdiagnosis about this disorder. And there was a statistic that I saw that it typically takes up to 5 years for someone to accurately get the diagnosis.
Yeah, and in her case, it was 3 hospitalizations.
And that's what I was going to say.
Yeah.
I was going to say, and probably at a much older age.
Yep.
So we're missing the boat when we're misdiagnosing. And I often wonder with this upsurge in bipolar in children, how many of those kids are really borderline? There's a stigma about giving the name. People don't want to give the name. And actually, I think that it's stigmatizing and perhaps unethical not to be diagnosing someone so that they can get the right treatment. If they get the bipolar disorder diagnosis, they'll be put on medication. There's no medication for borderline personality disorder. And oftentimes you'll see that people are on 5 or 6 medications because there is no medication.
And I think the diagnosis is so important to get it early so the families can get trained. And DBT does involve families too, and again, as we talk about preventing suicide, we'll pivot to this. Having education is like a toolbox. The more tools you have at your disposal, how to communicate to somebody who you think could be suicidal, whether it's borderline personality, major depression, whatever it might be, is so important. So the earlier you get the right tools, the better the outcomes are going to be. So going down that road, what would you suggest to people who are concerned about a loved one or a friend who might be suicidal? What are the right steps to take?
Well, so I'm going to break it up into 2 categories. So I think that the peers are the key to a child or a teenager in trouble. And I want to encourage what I've heard happens at a school in Connecticut, where there's one person designated to be the confidential person that peers can go to and say, I'm worried about my friend, and then begin the ball rolling. In terms of adults, I think we need to seek out mental health professionals, meet with somebody, go through your concerns, and find out if this is, something that needs serious consideration. And of course, there are the hotlines. People need to reach out to the hotlines as soon as they feel that there's something that's happening.
And we have a lot of 800 numbers, the 850 suicide, I believe is one, but we'll get those on the screen. It's so important that people know the resources are there. But
exactly. And I think also there's a fear about asking someone if they're suicidal and feeling that if they ask, then they'll do something.
Right,
and
putting the idea in their head.
Exactly. And those ideas don't come into people's heads like that. I think that if someone is showing signs of being suicidal, you're not going to make them suicidal by asking. You're going to show them that you're listening to them, validating that they're suffering, and maybe hopefully being able to get them the right help.
Right. And you touched on something I think is so important, the validation of their feelings, because for someone who hasn't experienced the type of mental illness or distress that would lead someone to suicide, you think it's like the farthest thing from your mind. So I think sometimes people's first reaction is to put the brakes on. No, these ideas in your head are wrong. But what's going on with that individual it's very real to them. So you really need to validate their experience. And although you can't totally empathize with them, listen, right, is the most important thing you can do, and let them express what's really going on, correct?
Right. And validation, people often hear that you validate someone, they feel that it means I approve of what they're doing or the situation. Validation circles around emotions. It's validating someone's emotions and letting them know that you understand what's going on for them and that you're there for them. You don't need to feel that you need to validate a situation that you don't agree with, but we can always find something to validate in somebody's emotional states.
Right. And of course, for a loved one, whether it's a friend or a family, a suicide attempt, or if in the worst scenarios of completion, it's obviously very, very traumatic. Can you talk a little bit about the family trauma and the PTSD that's involved in both an attempt or a successful suicide, and what we can do for
Yes, so I think that we are not recognizing the traumas that family members go through when a relative makes a suicide attempt. I know that one of the first lines and the first people called are involve the family. Call the family if the person's in the hospital or you suspect that they're suicidal. But, we train professionals with DBT and other modalities so that they know how to handle a suicidal person. How can we expect families to do this when they become the first responders without any skills? So I think it's important for us to realize that if a family member has someone who's suicidal or they've made a suicide attempt, that we have to realize that these family members go into their own crisis, that the family environment changes. Once there's someone suicidal, that family environment changes, all the relationships change. If they're, let's say it's a teenager, the younger siblings that are thrown into crises, and that we can't expect the families just to jump on board and know what to do. We need to be helping them.
Right, so a big part of, obviously, suicide prevention is educating families and having people understand what to do. Obviously, you talk about it's almost like that hypervigilance. Once you feel someone is suicide, you're too afraid to do the wrong thing.
Exactly.
And it's sort of like a paralysis by analysis, correct?
Right, and I think what we have to realize is notifying the families isn't enough.
Right.
I mean, these families, and I looked all over, I've contacted more people than I can even remember to ask if they have a program to help families. I haven't found anything where they're teaching family skills, how to help the families stay the course with their loved one. And we know from some research that I did with Dr. Jill Hooley that the more emotionally involved a family member is, the better the patient does over a one-year course. But we can't expect them to do it on their own. They need skills.
Right. And we've discussed this. People who've watched the show a lot, I talk a lot about recovery teams, and then that recovery happens best when the family member, the individual, and their providers, and a lot of times it can be several providers, not just a doctor, it can be therapists, all work together with shared goals and open communication. I think that's so important, especially in these most extreme cases, that people need to know if there's things that might set someone off or what to notice, like warning signs, and how to not only identify the warning signs, but how to react to them, correct?
Well, I think we also need to realize that not a lot, but enough of suicide attempts occur around communication or a relationship. And so if it's a teenager and it's in the home, the families, are already not being able to communicate effectively. So to expect that to change after a suicide attempt is too tall an order. The families need to learn how to have effective communication. And we then see a shift from people who go through this Family Connections program. Although we don't have access to the quote-unquote patient, we do hear, because we get emails from them saying, thank you, you've changed my parents, they understand where I'm coming from now, it's made all the difference in the world.
Now, obviously, this is a topic that always kind of gets a lot of attention, and like I said, something that's uncomfortable to talk about, but it seems in the past year it's gotten a lot of attention in the media there's been some celebrities who've taken their own lives, Chris Cornell and Chester Bennington, the musicians, but of course the show 13 Reasons Why, which was very controversial, and I know you haven't watched the show, so we're not going to talk specifically about, but there are some things that people pointed to that they got wrong, which we can discuss. Number one, they say the media should never disclose a suicide note, and basically the whole show is like one long suicide note, but I think people don't understand why that's wrong. Can you explain that?
Sure. So if we dramatize suicide, we're only encouraging people to think about it in a glorified way. And when I worked on an inpatient unit outside of New York, and once we did have a suicide on the unit, it was a very hard road to walk with the other patients, because we didn't want to glorify what happened. We were very confused if we should attend the funeral, because then other patients would see, oh, this is what happens. So it's a hard balance there. And when the media does, shows notes or glorifies what happens, we're promoting that thinking.
Right. It's very difficult because, like you say, you don't want to they put shrines up or things like that.
Right.
I think people think they're doing the right thing. They want to honor the person, and I think it's more important to honor the person's life than their death and learn. But one of the other things, and we've kind of already touched on it, I think that the show got very, very wrong, is that a lot of the warning signs were missed. The young lady who's the protagonist showed very clear signs, and at one point, her parents kind of miss them. But more disturbingly to me, the school misses it. There's a scene in the last show where she goes to talk to the guidance counselor, and you can tell he's trying to care, but there's a disconnect there. And I think that sends a very scary message that you can't get help, or you can't turn to people in your school. They won't understand. I mean, you mentioned some projects that are going on in schools, but schools need to do more, don't you think? I think we need to do more education in schools about how to recognize potential warning signs and how to intervene. Same as with families.
Yeah, no, absolutely. I mean, school personnel are not trained. So when they see that a kid is suicidal, that's frightening. And certainly, what we've seen over the last 2 decades of kids really having such problems managing their emotions, I think we're placing too much on the schools to do what ideally we would like them to do. I mean, I often hear that, we should, pediatricians are the people who can help find out who's in trouble. But in reality, how often does a child go to a pediatrician?
Once
And with all due respect to pediatricians, when they see cuts on a person's arm and the child says, "Oh, my cat scratched me," that makes sense too. But we're missing the warning signs, which are often isolation, starting to give away things, depressed, not engaged in the world. And then sometimes you'll see a resurgence of a positive mood, but that can also mean that the person has a plan and sees a way out, and that gives them a boost in their emotions.
Right. And you talked about some of the warning signs. Are there other ones that people need to recognize? Obviously, the disengagement, detachment, isolation, giving away things. You mentioned bodily harm, and I know self-injury is a little bit of a different thing, but is that a real sign? If your loved one is self-harming, is that how would you intervene in something like that?
Right. So self-injury, fortunately, has also become a little bit of a fad. So kids are doing it. If it's repeated, then it's a problem. If a child tries it once, it's hard to know what's behind that. But there's something called non-suicidal self-injury, and we know that that's not with an intent to die. But we also know, that it could be a call for help. It's also a way of managing emotions, and sadly, short-term it works. But we've also found that there's a percent of people who do that non-suicidal self-injury who do eventually kill themselves. So there is a correlation. So we want to be aware. We want to know that a lot of the behaviors are normal adolescence at an extreme, and that when there's a pattern and a duration, then we know kids are in trouble.
And we only have about a minute left, but that's another point I think we could do a whole show on. Typical teenage behavior versus troubled teenage behavior. So much to discuss. It's such an important topic. I think we may have to do a whole other show just on this. But again, if you want to learn more about suicide prevention or borderline personality disorder or the Family Connections program, again, there will be a training December 8th through 10th here in the Capital Region in Albany. We will have the website up on the screen. You can learn more. We'll also, if you want to take that training, you can email Perry directly. We'll put her email up on the screen. And again, she mentioned her colleague, Dr. Alan Frazzetti. I do want to mention he will be presenting at this year's NAMI-New State Education Conference, November 10th through 12th at the Desmond Hotel. And we'll also have, as you said, BPD will have a table as well for more information. And we'll be doing another session specifically on borderline personality disorder. But we are out of time. So, Dr. Hoffman, thank you so much for joining us and discussing this important topic and for the work that you do every day.
Well, thank you, and thank you for your ongoing support. It's so appreciated.
Again, and as we say every time on the show, hope starts with you. So thank you so much, and thank you for watching.